Hello and welcome to the Days of Learning podcast. Excited to be here today. I'm David Nelson, your host, and today we are talking about the future of healthcare part 2. And I'm so thrilled to have my good friends and colleagues, Dr. Brian Johnston and Krista Tumela, both former students and currently early in their careers in medicine. Good to have you, Drs. Johnston and Tumela.
Hello.
Good to be here. Thanks, Dr. Nelson.
You know, I want to get right into it because I think the audience doesn't want to hear me. They want to hear you guys. You know, I've known you guys since you were students. I remember the day you walked into my office, but I don't know if I've ever heard your stories. I'm going to start with you, Dr. Tumela. Can you tell us your story in medicine? How did you get to this point to where you are now?
Yeah, definitely. Well, I was born and raised in the Upper Peninsula of Michigan in Iron Mountain, where my grandfather was a rural family medicine doctor. So I spent most of my life like hanging out at his office and also seeing how he worked in our community. And I thought it'd be pretty cool to have that role as well. So when I went to undergrad at the University of Minnesota, it seemed like a no-brainer to study biology, and I was straight on the pre-med track. During my time there, I dabbled a little bit in basic science research, but then also some community engagement work focused on like nutrition and health literacy, particularly with family meal planning. And then I came to the Medical College of Wisconsin for medical school, where I met you and I met Brian and Ahmad, and we started working on our food doctors project, which was really rewarding, and I'm sure we'll talk more about that later. And ultimately through medical school realized that I loved community engagement, but I also really liked taking care of adults and kids, particularly in an acute care setting. So I decided to pursue training in internal medicine and pediatrics. And now I'm a fourth-year resident looking for my first job, hopefully as an academic hospitalist, where I have the opportunity to work with trainees of all levels, take care of sick patients, and then I'm hoping to do some academic and scholarly work still within the community. So I'm excited to see what the next step in my career is.
You know, that was quite a journey in 2.5 minutes, 25 years or so, and I want to go back. I gotta go back because I love origin stories. Mm-hmm. Tell us about your grandfather.
Yeah, so my grandfather, Dr. Edward Cadlets, he was born and raised in the UP as well. He worked as a medical tech and a radiology tech for a number of years before going to medical school in Des Moines, Iowa. He did his training in the Lower Peninsula and then came back home. So he owned a private practice with 3 other physicians. And he did everything from like small surgeries, OB, deliveries, house visits. And to me, that's what a doctor was having these relationships with families and with communities. Still, when I go home, people are really excited that I went to medical school, and they still talk about what my grandfather did for them and their family. And,
what did he impart in you, Krista?
I remember him talking, well, mostly to my mom, who's then passed on the message because he passed away when I was in high school. Unfortunately, he had Lewy body dementia. And so most of my adolescent life, when I would have loved to have these conversations, he wasn't able to. Mm-hmm. But my mom always talked about that he said he wasn't the smartest person in his class, or he didn't get the perfect grade in organic chemistry, but he felt like having that connection and that relationship with his patients is what made him a great doctor. And he never turned away anyone. He often accepted bread or eggs as payment, which I wish we could still do that these days. And he never really retired. He loved his work so much that even when he was in his nursing home, they gave him a clipboard and a piece of paper and a pen, and he rounded on the patients. Oh my gosh. At his nursing facility. That precious. Mm-hmm.
You know, I love origin stories because it's one I've never heard. I knew your family, you had family lineage in medicine. That's pretty special. And I know that he influenced you. Dr. Johnston, good to have you on the show with us. You are an assistant professor of family and community medicine. You have gone the pathway from medical school to residency and now to faculty. Talk to us about your origin story, how you came to be in medicine.
Sure. Yeah. I'm still resonating with Krista's description of her grandfather. He sounds like a really awesome guy. I don't have quite such a hollowed figure to guide my path, but I think my direction was also strongly influenced by those early days too. I came from Olympia, Washington. That's where I grew up. It's kind of a hippie town. We very community oriented, really focused on taking care of others and watching out for neighbors and thinking about community as an inclusive way, which was really, really, I think, impactful for me. My mom was a teacher and a music teacher, actually, elementary and middle school orchestra teacher, actually. And I think she just really imparted education and teaching as a really critical aspect of my identity. And then my dad was really into cars, so he brought that part too. So actually, when I went to college, I studied engineering. I went to college in Los Angeles, and my thought was that I was going to design cars, believe it or not. And we had worked on cars when I was in high school, and kind of spent a bunch of time under the hood, and we rebuilt an old Mustang, and I really came into the wider world, I guess, thinking that was going to be my direction. I quickly fell out of that. I went to University of Southern California, where there's a lot of kids in my dorm were driving in these brand new fancy cars that I could never, when you'd see one of those in Olympia, you'd watch it all the way down the road, because that's like the only, it's a rare thing to see. But then, the parking structure at school is just full of those things. So I guess I kind of got disillusioned with that path pretty quickly. But being in Los Angeles was a really different place, as you know. I remember early on connecting with some outreach to the homeless community there. There's a part in downtown LA called Skid Row, where a lot of people sleep. So it's a temporary community that evaporates during the day because it's actually in front of businesses, and they get cleaned out. And then at night, around 100,000 people will come in and set up their community. And every day it goes like that. So they have to leave during the day and they come back at nighttime. And that was twice as big as my hometown. So that just kind of set me down the pathway to thinking more about how society works and what role I can play there. So there was a few kind of things after that. I thought about going to medicine, kind of taking that science interest and background and turning it into a medical career right after college, but it wasn't really the right time for me. I ended up spending some time in community-based science education. So taking that engineering, connecting it to the community, and doing work with kids and families in parts of the Bay Area and then in Bronx, New York. That was a really, really cool experience too. I think I learned more from that also. I worked in a community called Hunts Point in the South Bronx, where this community had the largest, it was a little peninsula in the South Bronx, the largest concentration of food in the world, actually, on that peninsula, because all the food that goes into New York City passes through these huge warehouses and distribution centers, and all the, tens of thousands of trucks can come in and out every day to that community and distribute the food to tens of millions of people throughout the larger New York City area. But that community didn't have a single grocery store, and this community of 10 to 20,000 people couldn't access that food because it was only available for a wholesale license. So seeing that environmental impact on people's health and well-being was really, really impactful for me, and kind of returned me to that interest of working on health from the skills that come from a medical career, but also that perspective about what really the situation is in communities, especially vulnerable communities and underserved communities.
I got to ask you because I want to ask this deep question in your origin story. And I put these three pieces together: education from mom, cars from dad, and this notion of community, both West Coast and East Coast. How does it all fit together for you for medicine?
Well, the cars are on the, the downside. I've got, a lot of med school debt, so no more fun cars. But the other parts really come together. I think, the opportunities and what my job is right now and what I get to do, I get to really do a lot of work and thinking about community and how health happens and how it looks for people, not to us in the ivory tower that we live in much of the time. But I think back to I think there's a humility about our role in healthcare and what the true impact of what we're able to do on the medical side is in terms of, adjusting medications, or, Dr. Tamila, you're sometimes saving people's lives in the hospital settings. That's a little bit, but looking at the overall role of what healthcare plays out in someone's health and their well-being, it's a pretty small sliver. I think the World Health Organization estimates it's around 10% of the overall health in someone's life. And those environmental factors and community-based factors are just dwarf that impact. So I think there are big opportunities to connect what happens in healthcare to what the determinants of health are happening in communities. So I feel really lucky to have some time and support to think about and work on those issues with communities. And the other side is the education side. So that was a big reason why I ended up going into academic medicine. It's because it's just so much fun to teach. You're Krista, you're in residency right now, so you're all, you're a resident, even though I kind of consider you a colleague, but you're just surrounded by all those layers of learners and all that eagerness and all that just moldability and that people looking for who they want to model themselves around and who they want to look up to. And it's just a really fun environment. And you learn so much with the questions that learners bring to you. And learners drive a lot of change and a lot of progress for us. So it's just a total joy to be surrounded by medical students and residents. And actually the other faculty I work with are fantastic too. And they're open to learning, and there's a thirst for lifelong learning that I think faculty are real good at modeling.
I'm going to bring Dr. Tamela into this, but before I do, you tell me how this fits, and you'll see if your dad would approve with the cars. Right, the right tool. Take your time. Do it right the first time.
Yeah, I like it. I like it.
All right. So so that fits to medicine then. So we can say that fits to medicine.
Great.
Krista, I know that you guys worked on this project called Food Doctors. All right. I want to we'll do a little storytelling here, and you're quite, we're all family here. And you met this guy who was a second-year medical student.
Right.
Right. And what was your thought when you joined him and Ahmad on the Food Doctors project? What did you think of these two guys?
Well, first of all, I was just thankful to have a project that was started and rolling. I was really interested in nutrition education, and I thought they were just like a funny pair, and I was excited that they wanted to go teach and had something sort of set up. But it was really cool together to continue to develop the project. And I guess for all of our listeners, it essentially was a nutrition and health literacy curriculum for elementary students in Milwaukee. And together we not only learned about nutrition, but made snacks together. And we had a lot of fun going in and doing the sessions. I can't even think of how many sessions we did between Milwaukee Academy of Science and Lake Valley Camp. I think back on it now, and it was like every month or every other week we were bringing our bins of snack supplies. I think I still have some of the Trader Joe's spices left over in my cabinet from our flaming hot popcorn recipe. But at the end, it was really the relationships and the excitement that I saw in the kids' faces when we worked with them that left me feeling really fulfilled. So, but yeah, Brian and Ahmad, they taught me, they included me, and I think that we made a pretty good team that led to something long lasting.
Well, you said they were funny, and I'm not sure I want to go into that, but yeah, okay, we'll leave it at that they were funny. Dr. Johnston, so you met this first year medical student, so it's only fair play that we turn around and say, what did you think of this eager and interested first year medical student when she joined the food doctors team?
Yeah, it was kind of interesting. Me and Amat, yeah, we were pretty funny too. We had like a whole shtick, and oh my gosh,
Yes,
it
you
was
did.
just, oh wow, that was a good time. But I think we always imagined that project and thought about its sustainability and the evolutions that program would go. And we had this imagination of the future vision, and yeah, Krista kind of made that happen. She kind of, it was, I don't think I knew you before, Krista, before Dr. Nelson connected us. I think it was kind of like routed that way. Maybe we met briefly, I don't know, but it was like you came from the ether. It was like you were like the embodiment of like what we had hoped for and what
Let's call it
before.
what it was. She knew what she was doing, and we didn't know what the heck we were doing.
No,
Well,
no.
maybe it's something like that.
I want to take it down a serious path because I want to hear both of yours comment on this. Because Brian, you said something earlier about your days in Olympia, Washington, and I really like this community as inclusive. How does that relate to this idea of nutrition education with third and fourth grade students from a major metropolitan area like Milwaukee? I'm going to start with you, Brian. Can you speak into that?
Yeah, I think there's a lot of different ways to go with that one, but I think what I'll talk about when thinking about inclusivity in the work that we were doing is that I think that a lot of people get left out of nutrition education, and a lot of people we think about food insecurity, and food is such a complex topic. You know, there's so many cultural dimensions to it, and financial dimensions to it, and you know, we hear about food deserts, and then we see on the provider side, we see diseases like diabetes and hypertension and obesity that are just rampant in our society, but concentrated in certain communities who also face those same barriers. So we kind of put it all together, but I think we forget about the nutrition education part, and I think a lot of people are excluded actually from really having solid nutrition education. So many of the schools actually in city environments, especially the poorer schools, especially schools serving students of color, do not have any nutrition education in their curriculum. It's been squeezed out by other competing interests and a environment that's really adherent to testing standards and things of this nature. And also sometimes lack of even leadership within the schools or expertise within the schools of those that can effectively teach nutrition. There's some deficits in freely available evidence-based nutrition curricula, although that has been changing a little bit in the last decade. So that was something that we really were struck by, was that our community partners that we connected with early on did not have any nutrition education happening in their schools for their students. And so those students were really excluded. They were not included in nutrition education just as a concept. So we were, one of our first questions as the funny part of what we would do is we would ask people about, we made lessons around foods that we knew the kids liked. So one of our first questions was like, who likes Flamin' Hot Cheetos? And every kid, raises their hand. It's like the notorious food. It's like the new Coca-Cola, it's like this zero nutrition food that a lot of kids are using their lunch money on, and they can go buy it at the the machine next to the cafeteria. So when we would ask, like, how many of you like ate Flamin' Hot Cheetos for lunch in the last week? And everybody raised their hand. How many of you had Flamin' Hot Cheetos this morning? And it'd be like half the kids. It's like, oh man. But so we built lessons around that, and we tried to meet the kids where they're at and bring them into the concept of nutrition. And at the end, we would when we go through our kind of nutrition lesson, we would design and have the kids be able to create their own healthier alternative to Flamin' Hot Cheetos. So we would use whole grain popcorn, and we would use more health conscious flavorings and things like that. And the kids, I think, I just loved their responses to that, and the way that they felt like we can create something and we can use this knowledge and manipulate our environment. And to me, that's inclusive, because that's bringing people in and sharing and doing it in a way that's acceptable to them.
Thanks for bringing us, you gave us a lot there. And Krista, I want you to take it, because he mentioned the idea of the complexity of nutrition, and you have training in this area. Talk about that complexity, as well as the issue of the cultural aspects, like he said with Flaming Hot Cheetos, and fit that into the concept of education and how that might work with children.
Right, that's a lot to unpack. So I think that my experiences both in college around like mealtime food preparation, and then my experience in preparing snacks with kids, is that people see food as sort of a center point of their life. So we have it as both like a source of nutrition, but also such a social concept for us. I think that one thing that made our project particularly special is that kids did feel included, and they loved having or playing a part in making their food. And there's just something that comes from that that's different than getting it from a vending machine. And then similarly with my work in Minnesota, that was taking families, teaching them nutrition concepts, and then making meals together and then sharing them together. But then there is the whole piece of like, how does food support your body, and like teaching that concept as well. So I think that it's something that we need to focus more in schools and our education, but then also like in our practice. So whether that's seeing kids at their well child checks, seeing adults at well child checks, and how we can like better implement this into a broader scale for everyone, it's an ongoing process for us.
Thank you for bringing in the idea of food as a central area of focus for the families and for the individuals. And you didn't mention it, but we have talked about the challenges that families often are faced, and Brian alluded to it, with children eating Flaming Hots, and did some earlier research where children as young as 6 and 7 are having to make decisions around food for their day, especially if parents are working or doing other things. I want to hear both of you, because you both take care of children and families in medical medicine and pediatrics, as well as in family medicine. Tell us what you've learned from the community in the food doctors fits into medicine today. Krista, I want to start with you on this one, because you're still in your early workforce, in the sense of you're still in training. How does it fit? Or in many cases, I also want to hear about how it doesn't fit.
Yeah, so I think that my young, naive self didn't really think about this prior to food doctors, but that kids don't necessarily get to choose the food that they are provided for their meals. And so I think that it's easy for us as providers to see children and see families be like, oh yeah, like you just need to cut out the junk food. But really maybe that's what's available to them. And so asking questions about where you get your food, what resources you have available. And this is particularly important when I've worked in our more urban clinics in pediatrics. because you have families that come in and maybe at first they are, I don't know if embarrassed is the right word, but they're shy to say that maybe they're having trouble getting access to food, but having an open question to them about where they're getting food and if there are ways that we can support them. I think that I've learned a lot, and why patients maybe eat what they do or struggle with obesity, hypertension, diabetes, and things like that. Versus when I'm working more in my suburban areas, we can talk more about food choices. So I think you just have to be humble when you approach patients and try to meet them where they're at and see in what ways you can support them, because everyone has a different story, a different journey, and different struggles, I guess. And food is no different than many other things.
You had said a moment ago that asking that question, where do you get your food? And you have found that patients and parents are embarrassed. And it's actually, I have a paper coming out that speaks to the stigma of having a physician ask families who are food insecure or are food unstable, because they may have food, but it's certainly not the best kind of foods for health. There's stigma, there's embarrassment, and there's embarrassment on both sides of it. I think physicians are reluctant to ask the question, and patients certainly are reluctant to speak into it. So yes, it is demonstrated that there is embarrassment there. Brian, you take it from Krista in what she was saying. You work with families and children together as a unit in family medicine. How does what she is saying resonates to you, or how do you see it differently?
Yeah, I totally love those comments about asking more questions. I think working with residents in my family medicine residency program and students, there's this thing where we talk about patients being overweight or obese or having diabetes or having hypertension, and we talk a lot, they're in their presentations, they tell me what they talked about and what the plan is. And often it's about what medication adjustments, they're intending to make. When we talk about obesity, it's almost like you can predict what they're going to say. And they say, the patient's, morbidly obese. It's like, okay, what are you guys going to do about that? And they'll say, well, I talked to them about diet and exercise. It's like, well, what did you guys talk about? And they say, well, I told them that they should eat more vegetables and, that they should exercise. And, they said that they would think about it. And, so that's what we're going to do. And it's like every single time, and you really have to push them to not just give the spiel. Like the spiel is like useless. The spiel might as well be like, the cloud passing over you, or I think, sometimes it's like, I gave them a handout about healthy foods, and it's like, you might as well just give someone like a picture of the moon and say, you should be going there. I'll see you there, without really understanding and asking those questions that Chris was talking about, getting into what does food look like for you? Like what is your understanding of food? Like, what do you eat? What are the challenges and barriers? Like, what the perfect meal looks like. That you should have a bunch of green stuff in it, but what is the preventing you? What are your barriers? What are the complexities around food? And if you can get into those questions with a patient and get them talking, not you talking, and you can often use that expertise that we have to help to identify, like, not everything. This isn't like a perfect meal plan. This isn't like, we're going to solve the problems today. We're going to just create this perfect intervention. But if we can come up with one or two things that we can really make changes on that are patient-centered, that really come from something that's acceptable to the patient and that's going to work for them, that's a big impact. And you can iterate on that. That's one of the things I love about primary care, is that you're going to have relationships with families and you're going to get to know them over time. And you can recommend one or two things today, And a few months from now or next month or whenever you see each other again, you can check in. How did that go? How did it go to think about, you know, packing some carrot sticks, you know, getting a big bag of carrot sticks, splitting it up into bags, put it in the fridge and handing one to each kid before they go out the door, you know, to school. How did that go? And, you know, what else can we think of to build on that? And you get places that way.
Yeah. I think you
Take
have
it, Krista.
Oh, I just was going to say, I think it's important to, and I've learned this through now my training, that it's easy to give the spiel, but people know the spiel already. And asking people where are they at and how are you feeling about this? I had a patient just this last week who needed to go up on some, you know, diabetes and hypertension meds. And I'm like, you know that you need to do diet and exercise, but where are you at in that? And she told me that right now her financial health was more important, and so she wasn't able to focus on that right now. And so maybe we picked one thing like adding the walk-in to help, and then you follow up. And I think that is a cool thing about primary care that I'll miss about hospital medicine. But really, patients aren't going to hear you unless your goals align with theirs and what's important to them. So I think Brian made a lot of really good points there.
I want to ask both of you why, and I don't want to focus here, but I got to ask, why is the spiel hard to say, is easy to say, but hard to take it to the next step? Where are we missing it with our workforce?
Krista, do you want to go first or do you want me to go first?
I guess I just like similar back to what we were saying before. I think you have to find how the spiel fits into each person's individual goals and asking them how you can support them in that. Because for some people, if the spiel leads to they just don't know that much about nutrition and they would love to talk to a nutritionist, then that's a really great and like pretty easy thing that we can hook them up with so that they can learn more. But I also, I just think that you need to find what's important to them, and you can give the spiel of eat this many fruits and vegetables and exercise this often, but if they don't live in a safe place or they don't have access to those fruits or vegetables, then like it's really hard to do what I'm saying and reading from the textbook. So, and oftentimes our clinics do have really great resources like social workers that can pop in and say, actually, like this is where your food stamps can be accepted, or this is a farmer's market that is like in your area, and they can actually help. So I think it's just connecting those pieces that really becomes our job.
I totally agree to all that. I think a couple other aspects are, one, medical providers are really weak in their understanding of nutrition. And I think they're especially weak in their like perception of confidence in talking about nutrition, because we don't, like, I didn't get any nutrition education in medical school actually, which was interesting. I think I learned about like how proteins are synthesized quite a bit, and what happens to glucose molecules at different points of your like cellular metabolism. But
is that the Krebs cycle?
Maybe, I don't know. I don't remember. but I certainly didn't get clinically and patient relevant education about how to talk about nutrition. I think we know some about it because of just we're, you know, health-minded people, and we read and we think and we have our own experiences. But I think that's one large barrier. Two, I think time is always a thing. So you know, a long drawn out conversation about something that's not, you know, what some people consider their expertise, their bread and butter, the medication adjustments that we're so good at. Three, I think this maybe is a whole other conversation, but I think medical providers who work in underserved city environments are often working across a lot of gaps in trust and There, for instance, racial and economic and social, and there are many, many, many barriers that I think you are having to cross to build trust. And I think many times we're not building trust, and trust is essential for having these conversations.
I want to go there, and I think this is an important thing. Dr. Tamello, you mentioned about connecting to community, and Dr. Johnson, you mentioned about that idea of building trust. How can we do better as an industry? And we're not throwing providers under the bus. We're not, because, you know, I've been married to one for a long time and I wouldn't dare do that. But at the same time, we have to have a responsibility in this to both connect and to build that trust. How can we support connections and trust building? Krista, I want to start with you on this one.
Yeah, this is something that I think a lot about, and I've thought a lot about. Well, first of all, I think working for an institute, like an academic institution, you need to find a place that's invested in the local community and can give the support, and because it takes time and it takes money and it takes people that are willing to do it. And so I do think it's really important as a healthcare organization to be present, not only, like Brian said, in the big ivory tower situation, like everyone knows where our hospital is and they know that's where they go when they get sick, but showing that the physicians and the nurses and the medical students are actively out doing service work and teaching, and that they are invested in our patients outside of the concept of them being sick. So I think that you do that through things that you've taught us, like building partnerships, meeting with local community leaders and organizations, but asking the questions of how can we support you, and making it a good bi-directional partnership and not like our interests placed on the community. And so I think it's just always a work in progress, and it's great when you have institutions that support and see that although initially it might not be the moneymaker, if it overall improves people's health and wellness, that actually can benefit medicine and the organization much greater than maybe like decreasing a hospital stay or things like that.
So I hope when you go out to your first job that you're asking the question, so how are you invested in the community? I love that response. What are we doing to make sure that we're connecting with our community in a deep and meaningful and bi-directional way? Brian, take it from Krista there. How do we better connect the industry to the community like Krista was talking about?
Yeah, I love that institutional commitment concept. I think we're seeing some movements in that direction, both at our institution and kind of nationally these days, which is exciting. Still a long ways to go for sure. I think the education aspect is a big part too. And we're seeing some directions there. I think we're really good at talking about this in didactic lectures, and we're getting better at doing experiential learning around community partnerships and community engagement at our institution and others. And Krista and my project is an example of that. I think an area that we are weak at that though is in the clinical teaching aspect. So how to take these ideas, these big picture ideas and intentions, and help learners and early career folks or older doctors, frankly, learn how to make that translation of all these ideas and concepts to the actual clinical care. Because I think we're not there. You know, our clinic has some things we're trying to do our residency program, like we have an urban farm in the yard, and we have we really focus on food. We have a lot of opportunities for patients to participate in nutrition education and cooking classes and food deliveries for food insecure folks and things like that. But even we have room to grow for sure in impacting that patient provider conversation.
So for both of you, you use the example of the farm at the clinic and the example of the class. what is that ingredient that needs to happen between the industry and individual community members? What is that stuff made of? Krista, what do you think that is?
You mean that can bridge that connection?
Yeah, it's a good word, bridge.
Well, I think you need to get people that are dedicated to doing it and passionate about it, because if you don't have passion for it and see the importance, then you're not going to have a sustainable, intervention and, place where people can trust in what you are teaching them. I guess that's a really good question that I need to think more about. I'm not sure what the bridge is besides people that are excited about it and then finding future generations that are excited about it. And perhaps that comes through working in the community, getting students and residents involved as well, and then like having them reflect and see what their perspective has been through those experiences and how they carry forward. Because for me, like it was all an idea or something that sounded nice, working in the community, until I actually had the opportunity to go do that. And so I think expanding opportunities for learners and building the next generation is extremely important.
You mentioned excitement, and I think that's an important thing. Brian, what do you think that bridge might be? I like what Krista, how the word she came up with there.
Yeah, I love that excitement, enthusiasm. I think that's there. I mean, if you read like the med student application essays, you've never seen a more enthusiastic and idealistic collection of one page papers. But I think that we're being funneled into a system that's really deeply flawed in some ways. So the healthcare system, and this is where I'm going to get a little bit, try to reconcile the idealism with what happens kind of in reality a little bit for some folks. So the healthcare system is, in our country, which is different than other countries that have wealth also, is designed to extract resources from the rest of society through billing and RVUs that are developing revenue. And there's all sorts of incentives for providers to maximize that and choose career paths that are going to maximize that. And doing things that are inefficient in that way, really you're swimming upstream. So you're really having to find a role, such as I feel really lucky to have a role where I'm a little bit insulated from that, and I have some time where I get to think and work outside of that during the days, and not just like in the nights and weekends, and not just at the expense of clinical efficiency. I have a little more time with patients, for example, and I work in an environment where we have resources dedicated to these food, which is not a big RVU generator. The farm we have is grant supported. So I think our healthcare system is a big impediment for providers carrying out and really carrying through the promise of that enthusiasm and excitement that our young learners often have, because it's not, the healthcare system is not aware of the importance of that in the way that incentives are distributed. And it actually actively discourages people from having those longer patient-centered conversations, and from being in communities, and from understanding the community that they work in, and from understanding how what happens in the community connects to what happens to their patient's health. All those things are strongly disincentivized by the way our healthcare system is organized and functions.
Mm-hmm.
Krista, anything else to add to what Brian just said?
No, I agree completely. When I went into medicine, I don't think that I pictured, I think I was pretty naive. I was like, oh yeah, I'll go take care of patients. It'll be a great life. And it is great, but it's much different than what I thought. I never obviously knew anything about billing and the way that things are reimbursed, and that, it obviously makes the institution more money to do procedures and not really focused on like our interaction with the community or prevention. So I think that there is room for improvement in that in our healthcare system, definitely.
Okay, so I'm going to ask it this way to both of you. And because we look at this as a bi-directional relationship, ours with community and community with us. So each of you gets to speak to your patients and to the community right now. All right. And here's what you're going to tell us. Okay. We have these things called diabetes and hypertension that are in your family. Here are the things I really want you to do. Here are some first steps that you can do. Brian, I'm going to start with you. You get to reach out to the community now and say, talk to your patients in an ideal manner.
All right. First thing I guess I'd say is these things are, here's why they're important. And I'd say something about, here are, some evidence about the prevalence and the degree of this issue in the community. Here are, what causes it, and we talk about that a little bit. And then, I think I'd get into a little bit of what, that it's not your fault, it's not your, the blame, I think, and the kind of guilt around that issue. And then I think I'd talk a little bit about what are some community engaged solutions to that. What are some ways that we can work together to get some of these issues solved. So I didn't give my great grand spiel, but those are some of the chapters of what we may talk about.
Where would you begin, though? I really do want to get into that, the idea of what recommendations would you make to get a handle on hypertension and diabetes?
Yeah, I think I'd start with food. So I think I'd talk through food that's important to prevent and control diabetes, and some community sources and resources where we could find that good healthy food. And maybe we do something like the food doctors, where we talk through some some really community based culturally focused reasons why, and lessons around that topic. And then perhaps we'd think in a community engaged way about resources we know are available in the community because we've looked into it, and here's some things we can do with those resources. Here's some really filling, affordable recipes that we can do that are good for hypertension, for preventing and treating hypertension, preventing and treating diabetes, obesity. Here's how much it costs. Here's how you can store it. Here's how, here's some other ideas to riff on it a little bit and try different things so that your kids don't get sick of it. Here's some, here's some other things. And then I'm sure you have some ideas too that you can improve on this, and let us know, and we'll get it back out to everybody. Let's make this a dynamic conversation.
I love that, because you're really taking it down to those things that are practical. It's perhaps less about the medicine, and we want to use medicines appropriately, but there are things that we can do that are right there in front of us that we can make a difference in this particular area. Krista, you had the benefit of hearing from Brian. You did a great job, Brian. I put you on the spot there, but you handled it, man. Krista, what would you say to your patients? Here's your opportunity.
Yeah. Well, first of all, I would essentially go in the same order as Brian. So the first thing I talk about is why do I care about diabetes and hypertension? They're those diseases that are somewhat silent. And so patients often are like, well, I don't feel badly, or why should I care about it? And not to bring a scare tactic in, but sometimes it is helpful if they've had like loved ones that have ended up on dialysis or like these other adverse outcomes that come from long-standing diabetes or hypertension. But then immediately going into like, it's not your fault because there are so many factors that go into it, but what are the modifiable risk factors that we can touch on? So like you can't change your family history and your genetic makeup, and you can't even really necessarily change the environment you live in, but we can, you know, come up with goals together to improve things like weight loss and diet and things like that. And then, you know, choosing one thing to work on at a time. And I think too, we can't forget, you know, we're talking a lot about the role of things other than medication, but it does depend a lot on the degree of their disease as well. So for some people, like that first visit might be getting their blood pressure under control with medication and sort of starting the conversation about lifestyle changes, but you need to like also reinforce the importance of some of these medications and adherence with that to keeping them safe. So I think it's different if you're talking to someone who has sort of borderline blood pressures or A1C that's going up versus someone that has full-blown hypertension or diabetes. But then like having to customize your your spiel for them, and then like seeing them more frequently and follow up and trying to figure out how you can tackle each step at a time together.
You know, I am so glad that each of you started with the phrase, "It's not your fault." You know, I am in a family of with a physician, and she doesn't care for me, but I know medicine through her, and I know the medicine through my students. But I'm also a consumer, and know of the times when you are made to seem like things that may or may not be in your control are deemed your fault. And I think that we can do better in that space. So I think even starting in that space is a great place to build that relationship with your patients. You know, do either of you have a success story, and I'm sure you do, of some time when you talk from this notion of, I care about this, I care about you, it's not your fault. And what happened? And I don't know if it's diabetes or hypertension or any other thing where you really worked with the patient to have some success for them.
I can start out if that's okay. So
yeah,
the patient that immediately jumps to mind is one of my, there's like a syndrome where young Black men kind of don't go to the doctor for a while. And I think that it's for a lot of different reasons. One of them being that up until the Affordable Care Act came through, you actually, Medicaid was very, very hard for male adults to access. So a lot of men in Wisconsin went without health insurance for decades. Until that changed. So I think there's this concept of just kind of not going in for care and kind of knowing that you should, but just not being able to. So there's this thing when and then perhaps there's some symptoms that bring them back in, and then we kind of discover all the chronic diseases that have accumulated over that time. And you know, the thing about, I don't have any medical conditions. It's like, well, that we know about, you know, and then we do some testing. It's like, okay, here we go. So I had a patient like that who was in his late 30s, Black male, and he came in for the first time since he was a teenager. And of course he had, you know, he was urinating a lot. He knew that was probably diabetes, but he just finally came in, and yeah, sure enough, he had full blown, you know, diabetes. So that, I think, was a sometimes getting a diagnosis like that, or having that, you know, interaction can be really terrifying. It can be really, you know, you can feel really helpless. There's a lot of unknowns. There's a lot of motivation also to learn. And so there's a lot of education and a lot of just like, what can I do? And sometimes there's a lot of motivation that comes from those times too. And this individual really came ready to tackle this, ready to do whatever he could to learn and do anything in his power to really change the trajectory of his health. And we worked together for several months. One of the first things we said, one of those first questions was, is this curable? And I said, yes, it is. It is. Diabetes is curable. And I asked him, do you know what the cure is? And he said, I have to eat better and I have to exercise. You're right. That is the cure for diabetes. Like, we can give you lots of medicine. That's to manage diabetes. Like, the cure is what you just said. And then we worked on those things, and he got connected with a nutritionist through our clinic. And he was like a sponge. He was like, whatever you say, like, I'm going to just really do that. So he dramatically changed his diet, and he increased his cardiovascular exercise quite a bit. He stopped doing the bench press, you know. He moved to the cardiovascular exercise, which is really critical. And he actually, over the course of that year, he cured his diabetes, which was a great accomplishment.
Wow, I love that. Krista, do you have a success story for us?
Well, first of all, I was going to say that's why Brian is really good at what he does. And that's why primary care and that continuity of care is really, really great. Obviously, I don't get that as often in the hospital, although there are patients that I see in clinic, but they see my preceptor when I'm not there too. I guess like I actually would pull from like a family story. So I had a family member that had type 2 diabetes as the result of obesity and had tried like everything in terms of diet and dietary modifications, and about 10 years ago had gastric bypass. And I was like sort of against it at first. I'm like, you can do this on your own. But seeing her go forward with the bypass as sort of the start of her dietary changes, like she lost 100 pounds, is now no longer diabetic, and has completely changed the trajectory of her health and her cardiovascular health. And so I think that I learned from that, like being open to what people are telling you they need to get started on their journey. And that was one of the best things that she did for her health. And I'm really grateful that she felt like that was what she needed.
Wow. So I want to ask both of you as we start to wind down, how do we build more success stories like this, like these two? What's the stuff that's made of? Krista, I'm going to start with you.
Well, I do think that success in patient outcomes comes primarily with trust. So getting to know patients, whether it's for a short period of time, like I will get to know them in the hospital, or like Brian does long-term, but building trust comes primarily from like asking about other things in life other than the health conditions, and then like following through on what you say you're going to do. So I try really hard when I say I'm going to come back and give you an update at this time, or I will call your, son or daughter tomorrow. I think that then when they feel like you care about them, which we do, then makes it more likely that they will trust our opinion and want to do things to better their health. But Brian can speak more to the outpatient and preventative care success stories, definitely.
Thanks, Krista. Brian, how do we build more success stories like what Krista just mentioned and what you talked about a moment ago?
Oh, I love that trust idea. You stole my theme there. From the healthcare side, I think that's certainly just a huge component. And what it takes to build trust is like, what are the specific activities that build trust? Like you named one, being really reliable. And there are so many like ways to build trust, but how do we teach people how to build trust? And I think that's a big opportunity. But I think there also, one aspect of the idea of more success stories is it doesn't always have to involve us. Like I'd love to be able to be part of every, have a bunch of stories I could talk about and, go on more podcasts and stuff. That would be great. But I think ideally the success stories would happen without my involvement, without any, it doesn't need a doctor to be part of that. And I think that looks more like investing more in community health and in community engagement, and in perhaps a success story is my patient doesn't develop diabetes because he understands, he gets access to nutrition education that's acceptable and you know, culturally appropriate, and he has access to healthy food, and he has access to you know, an environment that doesn't cause him to be constantly stressed and oppressed, and you know, raise his cortisol levels, and you know, perhaps he has stable housing he can count on, and perhaps he has other things that impact his health, so that there is no need for me to have a great story to tell.
Love it. Anything else you both wanted to share with our audience at this time?
I guess just that it was really fun to reconnect with both of you, and I love hearing about all the work that you continue to do for our community. So this is a relationship that I'm grateful for, and I always tell people how important mentorship is, and I love having friends that have similar values and interests. So thanks for putting this together.
Thanks, Krista. Man, what a joy to spend some time with you guys. I hope we can do this again soon, whether it's on a podcast or not, whether it's with a beer in our hands or not. I hope that happens again soon.
Well, I want to thank both of you for coming on today. I've learned some new things about both of you. We have spoken of the things that are important, both in the health space as well as the community space. And at the heart of it all really is that idea of building relationships that are long-lasting, that are meaningful, and that are full of intention. For Days of Learning podcast, I'm David Nelson, Krista Tumela, Brian Johnston. Thank you for coming on the show.
Thank you, Dr. Nelson.
Thank you.
Wow, that was quite a series of lessons by these up-and-coming physicians, people that care about the community and care about their patients. You know, they talked early on about their influences from family to the community to early experiences working in community engagement. You know, this idea of health, education, community connections is not new, but seemingly we struggle at times to best how to connect the community to the resources to access the health that might be possible. I think at the end of the day, they talked about the trust that needs to be built with the community in partnership that's intentional. I hope you enjoyed this podcast. If you did, leave us a note, send us a message. If you want to subscribe, you can subscribe to this so you'll get all the future shows. For Days of Learning podcast and YouTube channel, I am your host, David Nelson. Thank you, and continued health and wellness to you.